Hi, and welcome back to the Robbins Headache Clinic YouTube channel. We've been putting several types of videos on and we'll continue to add videos. This is the second part of our personality disorder in headache patients. It's a general overview of personality disorders and treatment, and then we're going to have a whole lecture on the bipolar spectrum in headache patients also. So in the first part of personality disorders, we talked about genetics and who has a personality disorder, and now I'm describing more personality disorders, and we'll finish up with treatment. Some of the characteristics that we were talking about, splitting, where people don't see anything in gray, they either love you or hate you, that's characteristic for personality disorders. The malignant, horrible loneliness, the chronic anger and irritability, and spending is an issue. People with personality disorders will constantly spend, where you go into their apartment and it's filled with eBay and Amazon boxes that are even unopened. It's not like manic spending from a bipolar person in a manic phase who will spend all their money and then some in one day, and it's this flurry of 24-hour spending. With personality disorders, it's more constant. You see their closet has 100 pairs of shoes. They have to travel with 8 suitcases, that sort of thing. Emotional lability, where they're up and down all the time, is constant. And a lack of resilience. If something bad happens to somebody with borderline personality, they tend not to recover. If they have some trauma at age 15 or 20 or 25, often they end up on disability, never going to school, never working, and that isolates them further in their late 20s and 30s, and isolation is a huge problem. Isolation is a problem in our society anyways, but with personality disorders, they turn off their friends and family. Everybody gets tired of them and says, just either get clean from the drugs and stop having drama and chaos and police, or we don't want to have anything to do with you. So they end up alone in their apartment, and they get more suicidal because of that in their late 20s and 30s. And they used to think that having kids would protect women from suicide. Actually, there's been several studies that women who are borderline personality who have children are actually a little more likely to commit suicide, so it doesn't protect them. They tend to be very aggressive, and problems interpersonally. There's always relationship problems at work, at home, with spouses, with kids. So these unstable relationships remain throughout life, although personality disorders often can get better in midlife or at any time if they stay connected with family, with friends, and with therapists. And poor self-esteem. Many people with personality disorders rely on a spouse for their self-esteem or rely on others for validation. They just never know who they are. Under stress, they tend to decompensate. So we try not to diagnose personality disorders under a severe stressful situation. For instance, a horrible divorce. If they're divorcing, it's a nightmare situation. Maybe if their spouse has been acting terribly, sometimes somebody will get hospitalized psychiatrically, get the diagnosis of borderline personality, but they're really not. When we look at personality disorder, it's the pervasive way of functioning throughout life. It's not just for a few months that they decompensate under stress. They can actually get personality disorders, borderlines, antisocials can get very paranoid under stress, that everybody is conspiring and out to get them. They have a lack of focus and direction in life. You look at the young man who's 29 years old, who's just blogging at home and not working, has no interest in getting out of the basement, and that's typical. And many comorbidities we have with, which is what else goes along with personality disorder, substance abuse, ADHD, often bipolar, so you have this personality disorder and bipolar spectrum, sometimes eating disorders, and of course anxiety and depression. So other things go along with personality disorder. The personality disorder triad we talk about where it's victim, rescuer, persecutor. And in different situations with headaches, people often come into a clinic as a victim. The bad doctors, the therapist sexually abused me, they're always a victim. The emergency room won't give them enough painkillers. The pain doctors won't treat them or give them enough painkillers. And then they can turn persecutor. Persecutor is what leads to violence. The horrible man, I think it was Norway, who took the boat to the island and he shot 92 kids a few years ago. It was a Boy Scout camp type of thing. He ranted and raved, and he's still ranting and raving in European courts about having to teach everybody a lesson. Some of the personality disorders feel they constantly have to, they're a victim, and then they have to teach everybody a lesson. Spree killers almost always are paranoid personality disorders. So we have victim, beware of the person who's constantly a victim, and online I see this actually playing out with personality disorder pathology online, where people are constantly the victim on chat boards. Their brother is always dying. Their mother has abused them, this and that. And sometimes it's made up, sometimes it's real, but everybody comes around and doesn't understand that this person just needs the constant attention and sympathy. And often a rescuer. So personality disorders can be actually good rescuers as healthcare professionals, etc., but often it doesn't work out right. The classic is the fellow who goes from smaller town to smaller town saving the church. He rescues and saves the church, and then he steals all the money. And then he goes to the next town and saves the church and then steals all the money. Before social media and police were interconnected, they couldn't figure out that these were the same people. If you watch American Greed on CNBC, it's a fabulous show. It's an hour-long show about the Bernie Madoffs of the world, the scam artists, a lot of Ponzi schemes, and they tend all to be antisocial personality disorders. They're very charming. The flip side of personality disorder often is a real charm. They suck people in. They get people to marry them. So often they'll have 4 or 5 marriages that end up the same way. It's okay for a little while. People can hide their craziness for a while. They can hide their pathology for a while. But then it squirts out, particularly if you have a kid or two or under stress, and then it all falls apart. Once people turn persecutor, medical clinics need to button up and treat it right, because often medical clinics don't treat these people well. Say George is the person with the paranoid personality disorder, and he is constantly angry, and he calls and he says, Dr. Robbins, I need to talk to you right away, or he screams at the staff. And most staffs and most clinics don't handle this very well. Instead of setting boundaries and limits, and no, George, you can't call and do this, because they really want boundaries and limits, the clinic will roll over and say, okay, we'll put you right through. And so that goes along for a while, and then at some point it all explodes and falls apart because people need limits. So the mistake is to enmesh more with people who have a personality disorder who are angry. Say you take a condo board and they're suing, the personality disorder is suing, and the natural thing is, well, we're going to counter-sue, we're going to teach him he can't do this to us. But the personality disorders often like the enmeshment legally, so there's multiple lawsuits. The idea is to unenmesh and set boundaries and limits. So often the personality disorders flip between rescuer, persecutor, savior, persecutor, and victim. And they will come into a medical clinic as a victim, but don't always stay there. What they often say is, every doctor is treating me terribly, and they tend to see things in black and white and idealize. So a common first visit is, at the end of the first visit, doctor, every other doctor has treated me terribly, it's been horrible, but you are the greatest, and I love you, and I'm so glad I found you. And that's okay for a while, and then it tends to fall apart. So turning more specifically to borderline personality, what we spoke about in the first part of our talk on personality disorders fits mostly into the borderline realm. It's an enduring, pervasive pattern, usually starting in childhood or by age 15 or 20. Sometimes it can start in the 20s, but usually by late teens at least. Almost 3%, about 2.7% of the general population is borderline, but there's mild, moderate, and severe. Mild, some people can have some insight. Lack of insight is common in personality disorders, but some people with mild borderline will have some insight. Excuse me. And people might come in and say, I've been diagnosed with borderline personality disorder, and people are willing to talk about this more, and doctors and social workers and nurses diagnose this more than they used to. We used to not talk about personality disorder much, and it was shoveled under the rug. People will say, I've been diagnosed. There's some famous athletes, for instance, Brandon Marshall, who used to play for the Chicago Bears and then the Jets, was a spokesperson or said that he had borderline personality. I thought it took a lot of courage to come out and actually say that, because saying personality disorder has sort of a negative, pejorative, demonizing quality to it, so that's one reason why clinics and doctors were reluctant to label people. The diagnosis can change over time. People can get better. They can get worse. But if you look at 16-year-olds who are diagnosed with borderline personality, by age 29, at least a third no longer have that diagnosis. They may not be normal. They may still be irritable and angry, but they're not a personality disorder. Now, people say, well, how can you diagnose an adolescent with a personality disorder? Part of it's the level of drama. You know, there's level 1, 2, and 3 drama, I call it. Level 1 is my boyfriend hates me and my hair is terrible. Level 2 is the usual drama. Level 3 is personality disorder drama. Cutting, they self-injure and cut, police, drugs, real craziness, impulsivity, jumping into a car with older guys who are doing a lot of drugs, etc., etc. So there is levels of drama and chaos. Some patients have said to me that they were labeled the drama queen of high school, and they didn't realize that they are the ones who create the chaos. They always thought that it just followed them accidentally. Genetics, borderline is 5 times more common in relatives. We look for mental illness in the family, institutionalization, severe bipolar, severe hospitalizations, and mood disorders and substance abuse are more common in families with borderline. Mood instability and abandonment fears. People with borderline are constantly fearing that they're being abandoned, and then they react angrily and they split. So they'll love the doctor or their spouse, and then when they sense an abandonment, the doctor says, I can't treat you, or the spouse says they're leaving. It brings about, instead of the love, the hate, and they may turn their anger on that person. Low self-esteem. That malignant loneliness is a problem, where it's just this inner feeling, and that leads people with borderline often to constantly have to have somebody else in their life, romantically or sexually. They'll go out at 1 in the morning if they've broken up at midnight to find somebody. They can't be alone. And quick shifts in moods are common. The not being alone is a major issue. If we can, we try not to hospitalize people with borderline, because the biggest time for suicide is within 2 or 3 days of leaving the hospital. They get all this attention, caring, groups, and then they go back to their apartment and they're lonely, and that's the time that they shoot themselves. Impulsivity is a hallmark of borderline. Speaking of shooting themselves, it's a bad idea for borderlines to have guns, because suicide is very complex. Sometimes it's thought out and there's long periods of thinking about it. Sometimes it's an impulsive thing. Sometimes it's in the middle. They're driving 80 miles an hour, they've had a couple drinks, and if they hit the wall and die, they figure, okay. If they don't, okay. It's not that they're wanting to kill themselves, but it's in that gray zone. We look for impulsivity to be improving by age 22 or 23. If it doesn't, that's not necessarily a good sign. So impulsivity in the early 20s is a good marker to see if we can predict how people will do. Cognitive impairment under stress is common with borderline, substance abuse and self-medicating, and paranoid thoughts, particularly under stress. Sense of entitlement is common with borderline, that severe sense of entitlement, not just mild, but they look down and demean everybody beneath them. Wait staff and helpers at the department store are treated terribly. I mentioned splitting. Some patients that I ask, can you see the gray zone, or is it always black and white? They say, no, I either love somebody or I hate them. And they can't see in the middle. The constant shopping and spending is a borderline hallmark. The chronic mood instability and also use of health care. People with borderline are in and out of emergency rooms a lot. We see it in a headache center or pain center see it. They tend to go to doctors more. Self-injury is common. And I mentioned suicidality. Suicide's a big issue. So one thing is we try not to give people with borderline personality drugs that would make it easier to kill themselves, particularly the combination of opioids, painkillers, and benzos, Valium, Xanax type is a bad combination for stopping breathing. Borderline tends to be aggressive and reckless. The chronic anger and irritability, lack of resilience, and they have very negative emotional overreactions. They overreact with anger to a tiny slight. And people with borderline often will never forget that slight. 10 years later, they say at a family gathering, and borderlines will sometimes ruin families often. So you get to the Thanksgiving and the person's really angry with Uncle John, and you say, why are you so angry with Uncle John? 10 years ago, he said this about me, and it was like nothing. John 10 years ago said like a nothing thing that maybe, her rug in her house was, a color brown or something, and it meant nothing. But they hold on to these slights forever, and that will ruin families, and it can ruin relationships. That persistent dysphoria, persistent depression, up and down, irritability is common, and disturbed relationships. So some examples. These aren't all written in stone. It's always tenuous diagnosing personality disorder from afar, but Hitler, you could argue that he was several types, antisocial and paranoid and borderline. The thing is with most personality disorders, they have features of this type and features of that type. So they're artificial types that they've grouped them into, and now it's DSM-5. But it's really a spectrum of personality disorder. Charlie Sheen probably, he may be bipolar also, but he definitely has that anger and splitting. Lindsay Lohan creates drama and chaos wherever she goes, the chronic spending. There's some movies, Misery, which has been a play, Mommy Dearest, Silver Linings Playbook with Tiffany, and the classic was Glenn Close's character in Fatal Attraction, where she loved and idealized Michael Douglas, as you remember, and then when he abandoned her or she sensed it, it turned really ugly. And I don't know if you remember the bunny scene, but it was, it's actually a great movie, but scary and very realistic. So I mentioned in adolescence, the level of drama is high, but we always remember in young people, borderline has a very good chance of improving. It's called plasticity of the brain. Really our white matter tracts and most of our brain has a good chance of recovering and improving, particularly if people stay connected, have strong family support, and a therapist. Parents need help with all of this. There are a number of good resources. The eggshell books, Walking on Eggshells, What to Do When Somebody You Love Has Borderline Personality. There's Demystified, Borderline Personality Demystified. The Family Guide to Borderline Personality. And if somebody has a parent who has a personality disorder, is very narcissistic, there's Children of the Self-Absorbed is a decent book, and there's Surviving a Borderline Parent, which actually, these help validate people because they lived with it, often go through therapy for 30 years, and by age 50 they figure out how to deal with their mom who is a moderate or severe borderline, but it takes years and years, and the books can help, therapy can help. But years ago there were no books and people didn't go to therapy and they had to work all this out on their own. So management of borderline, some of our goals are to improve functioning, impulsivity, we want to decrease, lessen suicide behavior. We have limited expectations, we're not going to cure people. Therapy has limited expectations, we take more of a behavioral, what to do today and tomorrow to feel better, not a cognitive approach going into childhood issues so much. Boundaries are crucial. We need to keep a distance. People with borderline and other personality disorders often will cross boundaries. So, and they idealize you. So they might say, Dr. Robbins, I'm in business with this. Come on in business with me, or do this. Let's do this project. And getting enmeshed when doctors do is a bad idea. So we need to keep boundaries very much. We take a dialectical approach, which is go with the flow. Dialectical therapy has been the vogue for personality disorder as opposed to insight-oriented cognitive therapy. So people with personality disorders have been told that they're doing things the wrong way or their view is so wrong their whole life. We don't hit them over the head with everything and say, no, you're wrong, you're wrong. If it's not crucial, we go with the flow and take an easier approach. There's a condition called Munchausen's by proxy. They've changed the names now. DSM, it's called factitious disorder perpetrated on another. But basically, it's somebody making their kid sick usually. It could be a caretaker with an adult, but it's usually a kid who's sick. And Munchausen's, it doesn't have to be severe. It can be mild, where they are just bringing their kid to a lot of doctors, and they're not making them sick, but they go in and out of the emergency room, the hospital, the doctors with their kid. Their kid doesn't go to school. And it's not that uncommon, this mild factitious disorder by proxy or mild Munchausen's. And we take a dialectical by proxy approach, dialectical approach to the moms in this situation where we don't hit them over the head, we don't confront them so much. We try to ease a separation with the kid, and particularly at the end of high school, and we've had some success. Almost always the mom is a borderline personality disorder, and if you confront her, and I say moms because 95% of the time it's the mom in these situations, if you confront the person, they split, and that's the last time you see them, and it doesn't help anybody. So these are delicate situations, trying to protect the child, but also keep the person and the mom in some sort of therapy, limit how many doctors they go to, and get a separation, do a momectomy at the end of high school and get the kid away. That works unless the child is fairly ill psychiatrically, and then nothing really works that well. If the kid is also a personality disorder, and you look in the 20s, they're not doing well. But otherwise, following these people, there's been a couple studies till their 20s, the child is often doing surprisingly well. But it takes a village to help these people. We need psychotherapists and psychiatrists and pain clinics. So sometimes we don't go it alone, we get other therapists involved. We try not to get caught up in the drama and chaos of borderlines. They can try to hook us into their drama and chaos, barging into a clinic or coming up with a story that they were just in an accident and this happened and that happened. And the idea is to dial down the drama and chaos dial. They often manipulate, they're needy and demanding, some of the patients with borderline, and we need to recognize that and not be manipulated into giving large amounts of opioids particularly, and that's a common manipulation. As providers, the idea is not to get burned out. 58% of headache docs and nurses are burned out, according to a recent study. And once a doctor is burned out, what does that mean? Well, it means they don't care as much. They're tired of the whole thing. They're tired of the paperwork, the patients. It's not good for them, but it's not good for the patients at all. So protecting from burnout, and that's protecting from severe personality disorders, talking to staff, having people to talk to helps very much. Clinics deal with borderline rage differently, that anger, and in some big institutions, they can't deal with it effectively. They can't dismiss patients or set limits nearly as easily. So treatment outside of long-term psychotherapy is very important. Trying not to give opioids and benzodiazepines or in limited amounts. We stress social engagement and not being isolated at home. And that's crucial. Social rhythm therapy. We try not to hospitalize psychiatrically because of that few days afterwards is a high risk for suicide. Some people do have to get hospitalized psychiatrically if they're actively very suicidal. And we are wary of invasive procedures. We want to limit surgeries or because people present themselves to medical clinics as a victim and they tend to get over-surgerized. They get too many invasive procedures, and we need sometimes to protect people from themselves. Medications can help borderline 15, 20, 25% with the anxiety, depression. They're not a miracle, but the antidepressants, the anticonvulsants, the seizure meds that help moods, like lamotrigine and oxcarbazepine. And in the next sections, we'll talk about bipolar and the medicines. We need to be aware of suicide risk. Antidepressants can help, but we're always wary of triggering if people have some bipolar brain chemistry and they're borderline. We don't want to trigger that hypomania or mania. And we need to limit the medicine and minimize medicine is part of the idea. For anxiety, we want to use non-addicting medications, the anticonvulsants, antidepressants. Hydroxyzine is actually a nausea, vertigo medicine that's not addicting that can help anxiety. And gabapentin is a mild medicine that helps anxiety in some people, and sleeping is not addicting. And then we use what we call atypicals, quetiapine, Risperdal. There's some new ones like Rexulti, and Abilify is now generic, aripiprazole. And these atypicals can help calm moods and sometimes help the depression as well. So a little bit about other personality disorders. They all tend to be a spectrum. Paranoid are the spree killers that I mentioned. We tread lightly with paranoid personality disorder. One thing about paranoid personality disorders, they tend to be ultra frugal. I'll ask them, why don't you spend more than $3 at a time, even though they have a lot of money at the pharmacy? And they'll say with this anger, you know, I can't stand to give that pharmacist more than $3 at a time. And I've heard that. So paranoid personality disorder is not that common. As I mentioned, they're dangerous and we're always worried about violence. But it's much less common than borderline. Antisocial. Antisocial is not a great name. You have the violent antisocials who are in prison a lot. Then you have the scam artists, the Bernie Madoffs who run Ponzi schemes, or Leonardo DiCaprio in Catch Me If You Can, who was very good at pretending to be a doctor and an airline pilot, et cetera, et cetera. The scam artists are, the antisocials and borderlines are very good at being scam artists because they can lie. They've lied their whole life, and they do it fluently, and they don't care. They're actually very good actors. Narcissistic personality disorders, some of our politicians, they can be very vain, thin-skinned. Thin-skinned is part of borderline and narcissism. Dependent personality disorders are more common than the others, dependent and avoidant. Dependent, they get dependent on a spouse or a family member, and we would think that dependent personality disorders do well in relationships long-term if they fit, but it doesn't always work because the spouse can't fill them up. They can't fill up those needs. They're so needy, and then they get angry, and it ends up splitting the relationship very often. The most common personality disorder is avoidant. where people are basically avoiding social situations. They're alone in their apartment. Sometimes they come into a medical office with a mask on, where they have allergies to everything in the environment, which sometimes can be real, but sometimes can be part of an avoidant personality. And they tend to be isolated and end up alone. Now, families of those with personality disorder, patients who have a son or daughter, we try to get the books. We try to have them understand to set limits, because often these children will ruin the whole family's life, the children in their 20s, with spending, with police, with violence, with drugs. So we try to have the books like the eggshell books, etc. And when people have a spouse with a difficult personality disorder, that is very difficult going through a divorce. Many people will put off divorce for a year or 2 or 5 or 10 or forever when they're married to a borderline, because they know it's going to be crazy and anger and insanity. Normally we want to push mediation and reasonableness in divorce. It doesn't generally work when somebody's a moderate or severe borderline personality. So a case we have, say Caitlin, for instance, is a young woman with personality disorder, 27 years old. She might come into our clinic, this is a fictitious case, with chronic migraine, diagnosis mild borderline personality disorder, and mild bipolar. That's typical. There's a family history of substance abuse and bipolar. She comes in, she's irritable off and on with the staff, calling, sense of entitlement. She feels very lonely. She splits on her family and friends. So she's 27, Caitlin is by now, so only has one friend left. That's very common. But she also has a very charming side. Caitlin's in the emergency room often, and we notice right after taking her on as a patient that we're getting called from the emergency room every other day, because she's manipulating for benzodiazepines and opioids. She calls insisting on talking to just one person on the staff. She's mad at everybody else. She says, I only want to talk to so-and-so, and I want to talk to Dr. Smith, and this and that, this and that. And after receiving any sort of injection, if we do Botox for her headaches, there will be chaos and drama. She's laying down in the office, moaning. We need ice packs. We tend to her for hours. There's chaos and drama that follows people with borderline. So eventually Caitlin convinces a pain doctor to give her Vicodin hydrocodone, and then they discovered that she's getting it from 4 doctors, manipulating for opioids from multiple sources. That's common. So then she runs out and posts immediately terrible reviews on social media about those doctors. So that's the splitting. She loves the doctor and then gets back at them. And then Caitlin is kicked out of the office and then calls 2 months later wanting to return. This is a typical scenario for what happens with personality disorder. It goes off and on, sometimes most of the time. If somebody's severe, they end up getting dismissed from an office for behavior and they just go to the next office. But it brings about that we need to set boundaries and limits. So I'm going to wrap it up here, and our next segment we'll move on to the bipolar spectrum in people with headache disorders. Thank you.